Hello, I'm Scott Carson, Director of the Moneson Center for Business Research in Healthcare. Before the 2014 Queen's Health Policy Change Conference, I interviewed 3 international panelists from Denmark, Sweden, and Germany about their perspectives on developing national healthcare strategies. I talked to Professor Kirsten Verbeek, Department of Political Science at the University of Copenhagen, Lena Hellberg from the Division for Public Health and Healthcare in the Ministry of Health and Social Affairs, Government of Sweden, and Dr. Norbert Schmacke, Associate Fellow, Institutes for Public Health and Research in Germany. Kirsten, Lena, and Norbert provided an in-depth picture of their multi-jurisdictional system structures and how they have managed to collaborate to deliver patient care. Of particular note is the level of patient involvement mandated through policy with regard to service and funding agreements. Ultimately, we found a number of lessons that seem relevant to Canada's healthcare system.
Well, in a sense, you could say it's only partly true that Denmark is a centralized and national system, since we also operate with municipalities dealing with a lot of the public health and primary healthcare, and we have regions, 5 regions that are in charge of the hospital services and the more specialized care. But it's more, I think, central in the sense that over the past sort of 20 years, there's been a movement towards more power at the central level and creation of more coordination or better coordination mechanisms across the different levels. And that has very much been driven by sort of a feeling that might improve the quality or create more equality across these different regions and different municipalities as one thing, and the other thing by a strong drive to create better mechanisms to control the economic side of the system. So better sort of steering mechanisms at the central level.
So would it be fair to say that there's sort of national level coordination and
that's a good way of describing it. National
lower level delivery?
Yeah, that's a good way of describing it. And some of the instruments that are used are these annual negotiations between the national level and the decentralized levels. And that's really an important arena for coming up with new policy ideas and setting the targets in terms of the economic measures of expenditures and taxation levels and so on. So in that sense, there's a national coordination, and the state has become more important in terms of setting the strategy and developing the strategy. Yes.
So, Lena, how close would Sweden be to that? Similar or different?
In a sense, quite close, but there's a difference because in Sweden we have the government, government that is responsible for all legislation, and then we have 21 county councils. And then you have 290 municipalities. So we are also quite decentralized in Sweden.
What about in Germany?
We have three levels. The first level is the law level, which is put down in the Social Code, Book 5 in Germany. And this is, so to say, a framework for the development of the system, and defines the topics and the criteria how the system can be developed. The second level is the Federal Joint Committee, where to put it in an easy way, physicians, representatives of the physicians, the hospitals, and the sickness funds sit around a table. And the government decided a couple of years ago that patients' representatives are also new members of this Federal Joint Committee. They are not allowed to vote, but they are allowed to participate in all on all steps of the process.
So what sort of decisions would the Joint Committee make?
All important parts of our system. It's about outpatient medicine, it's about hospital care, it's about dental care, psychotherapy. Quality assurance is a big topic at the moment. The development of disease management programs for chronic patients, and of course pharma, right? The evaluation of new drugs. This is new in Germany, that all drugs which are allowed have market entrance have to be evaluated by the Federal Joint Committee at an early stage. And this has much influence on the price regulation.
Right. And so what about the third level?
The third level, and that is most difficult to explain, is the level of contracts between sickness funds, physicians, and hospitals. So to say, what really happens in the field is very much dependent on this third level. And the differences between our 16 lenders are due to this, let's say, politics of contracts. And so we have a way of sort of centralization. The benefit packages for insured are almost the same, but still in reality, the quality may differ.
What is interesting in each of your three cases is that if I were to say to someone that a national system is one in which sort of top-level control is imposed on others, that would probably be very difficult in each of the situations you've just described, because there is a fair bit of decision-making at much lower levels. Would that be a fair comment to make?
Yeah, it's definitely a fair comment, and it has been for a long time a philosophy that you should have sort of democratic governance at several different levels.
Yeah.
And you should have the ability to make at least some decisions locally or at the decentralized levels. And that also, one of the parts of this philosophy is that allows for experimentation, so you can learn across the different regions, the different municipalities. Of course, that requires that there's a central level that can take out some of the lessons and sort of make sure that the good examples are spread throughout the country.
So in the Swedish system, has the system been fairly stable, or over the years have you had changes to the structure of the Swedish system?
No, it has been quite stable, but I must say something that I forgot when you asked.
Sure, yeah.
Because we have the principle of local government autonomy in Sweden. Mm-hmm. That means that all the 21 county councils, they have the right to decide themselves how to provide the medical service. So we on the government level can't decide that. So that's what we can do is to make those agreements on in special areas. But how you will organize and the taxes that finance the medical care, the county council can decide themselves. So that's more like in Canada. Like but in another way, you have also the Health and Medical Services Act that says that the goal of the good health care and must be in equal terms, and that is very important in the Swedish system. So maybe that's a big difference with the Canadian systems, because that is all the Swedes know that, and they demand that.
Would that be fair to say that in Sweden there are certain coordinated accountabilities that each of the regions must meet?
Yes.
Because they're being funded from the top, are they not?
Yes, subsidies about 20% of all the revenues that the county council gets comes from the state, and about 70% comes from taxes. So, it's a bit complicated just in a few words to describe it, but often when we govern the county councils, it's more a system of if you perform, you can get money for it. That's in the last few years we have much more of that governed in Sweden.
Norbert, in Germany, the system, does it accommodate a mix between publicly funded care and privately funded care?
Well, in a way that's true, because most of the physicians are small entrepreneurs.
Small businesses, yeah.
Small, yeah. And about 25 or 30% of the hospitals are privately organized. And you asked if there are bigger changes in politics during the last, let's say, 10 years or so. That is a very good question, because what is an important change? We have lots of new regulations which don't make a difference in practice. For example, one of your big topics, integrative care, integrated care. Our law is fantastic. The Ministry of Health tried different times to enable integrated care, but the physicians, the statutory health physicians and the hospitals don't find a way to cooperate, and we don't find a way of cooperation between social workers, physicians and nurses. It's different. They represent different cultures, and we don't find a way to really make them work together. I mean, everybody would say I'm crazy putting it this way, but I'm absolutely convinced as a scientist that this is true, because we have no evidence of better cooperation during the last decades, and this is one of the big problems in a population with, let's say, a high degree of elderly people living alone. They need social support, they need nursing, and they need integration. Someone has to do it for them because they are not able. Even highly educated people have difficulties to organize their health care when they are severely ill. Right? I'm a little bit polemic, but I'm convinced of that. And most people are absolutely alone. So integrated care is a big topic, and we try to do something about it, but we're not very far.
What about Denmark in terms of integrated care?
Well, integrated care is a challenge in all systems, I think. But we've addressed it, or tried to address it, through a major structural reform a few years back.
Right.
Amalgamating the municipalities and making them larger, and thus enabling them to have better expertise and more volume in terms of their dealing with home care services and providing rehabilitation services, prevention services, etc. So on the structural side, that's one of the measures we've taken, and then we've at the same time institutionalized a structure where the municipalities have to enter agreements again. So the Nordic countries are very agreement-based. So the municipalities have to enter agreements with the regions, where they have to sit down and discuss a lot of the details of the integration. So for instance, what's to happen specifically when a patient is admitted to hospital, what are the types of information flows, similarly on discharge from hospitals. On the rehabilitation side, etc. So they make very sort of detailed agreements on what's going to happen with the elderly person at a particular point in time in regards to care.
So I'm very interested in how they come to these agreements, because Norbert just said that part of the difficulty in coming to agreements is cultural differences amongst the different parties.
That's where you see a strengthening actually of the state hand in healthcare. The state is forcing the municipalities and the regions to enter into these agreements. So they basically have no choice, and they have to, once they've signed the agreements, they have to send them to the central level for approval. And actually, the first time they did this, a lot of them were rejected. So they know it's a possibility. So they have to do this, and gradually, based upon that, has sort of evolved a consciousness and a culture of collaboration at the decentralized level, I think.
So are the Swedes as efficient as the Danes when it comes to coordination and collaboration?
I don't know. In Sweden, we have it's a challenge even in Sweden with integrated care, but if you compare to Sweden and Denmark, we don't have we more, the primary care is more organized in healthcare centers, where you have different skills in every center. You have doctors, you have nurses, you maybe have some other skills in that. So in that way, you can say that it's more integrated in the primary care, because they are just the next door to each other, and you can just ask someone else if you wonder something. So that's good in Sweden, I would say.
Certainly one of the themes of our conference is dealing with the integration in the system, and I think it would be fairly commonly viewed in Canada as our system is not well integrated. What would the situation in Germany be like in that regard?
Well, maybe our systems are more alike than we think in this respect. And I'm absolutely convinced in the meantime that this is more about culture than about economics and politics.
Yeah.
The people in the field are not really, well, they are not inclined to change their habits. I think social science has shown this all over the world, that physicians follow their own
Yes.
ideas, their own philosophy. There are differences between the countries. In Germany, the physicians are very strong. They have, let's say, a very difficult relationship to nurses. They just talk about delegation of tasks, not about substitution, not about own responsibilities.
Not about teamwork, but
teamworking. Yeah, everybody talks about team playing, but we did some research and asked nurses and physicians and GPs what they think might be better under ideal circumstances as far as team playing is concerned. We found no answers. They have no fantasy. We were very astonished.
Well, in terms of rigidities or impediments to change, certainly what you've just described, cultural difference is often one. You've talked about kind of the rigidities that result from cultural differences. So give me some advice. What should we be, what are some of the ingredients for system change?
One thing that we work more and more with since at least 4 years ago, it's patient empowerment. For example, we have in the beginning of in a half a year a patient net will take place, for example, and the patient is a more important in the healthcare and the development of the healthcare. And maybe, I don't know if it's true, but I just that the patients say that they want to take part in the development of the healthcare in Canada also. Maybe that can change the way to work.
Well, I mean, that's a very good point, because patient-centeredness is coming to be a very common theme all across Canada as an important driver of change. Is that true in Denmark, would you say?
Yes, there's a fair amount of patient involvement, and it's sort of institutionalized at the different levels, so they participate in these healthcare negotiations around the agreements between the regions and the municipalities that I talked about before. And at the national level, some of the big patient organizations like the Cancer Society are very sort of active in terms of putting issues on the agenda and doing their own research to sort of push developments in particular directions. So yes, patients matter. But if I were to point at some factors that were important in terms of the Danish reform we had a few years back, they would be, first, you need to have some stakeholders pushing for this, both sort of within the political system and also external stakeholders. So you need to get the important people and organizations on board. You need to have a parliamentary situation where you have the majority and you have people that are willing to invest their political capital in healthcare as the area that they should go for. So you probably need to have the top government management on board in order to do this. Then you need to, if you don't have a disaster, then you need to create at least a story about a need for change. So, and the way that was done in Denmark was very much to point to the future, so demographic changes and more chronic care needs in the future and so on. So saying that the system may work okay now, but it's going to come under heavy pressure in the future. And that worked well in Denmark because at the same time you had sort of an economic situation which wasn't great. So if you have the economy pushing as well, And then the fourth element, I think, is sort of management of the political process. So you need to have a government that's able to sort of do the right things at the right times, to create the strategy, to pull the pieces together. And there can be a variety of different ways of doing it, but at least in the Danish case, through organizing a national commission and to controlling fairly tightly what came out of that commission and using that as a stepping stone to create the story about the burning platform.
Is getting the public well informed an important part of the change process?
Well, patients' participation is really a big thing, and for my feeling, this is would also be a big step for the development of clinical study designs. Why do we not ask the patients what they think quality of life really means to them? Why don't we ask them? We have a lot of research on that topic, but we have not included it into clinical research to some extent. We try a little bit, but it's not a routine, right? If you think about solid tumors, if you think about metastatic stages of carcinomas, we have little progress, and we invest billions of dollars and euros into these sort of therapies, and we have and we started just, let's say, 10 years ago to develop what we now call palliative care, and early integrated palliative care, which doesn't mean more than we ask the patient what is important for her and for him. We ask the family and the friends, etc., and we honestly talk to them about their chances and the stages they live in. Talking is a big thing.
Well, it's a very good point, because just thinking of how change can come about and believing in the importance that people have to want change in order for the politicians to move forward. The people have to receive information in a way that resonates with them personally, and if through narrative and personal stories, that's how best you come to educate the public, as opposed to giving them lots of economic data and facts about system performance. If that's the approach that needs to be taken, then we should do that.
You need to get the different stakeholders on board and active in the process and talking to each other, I think. And then you need to create the idea of the burning platform for change, and that can be both through these bottom-up type storytelling, and it can be through more extensive comparisons and collection of performance data, comparing across the different provinces, but also comparing Canada to perhaps some other countries than the US, so comparing to countries that are more similar in size and system operation. And then you need to get the top politicians interested in the issue. So not just the health people, but probably at a relatively high level in government to get this going.
I must say that our experiences with the patients' representatives in the Federal Joint Committee is really fantastic. At the beginning, many people said, how can they ever be part of such difficult procedures? They can. They have their own perspective, and they are so experienced in all these diseases we talk about as experts, right? It's really fantastic, and which does not mean that it's easy, and there's a self-fulfilling process. But this can help to develop confidence and the conviction that it's about better medicine and not about less money.
Well, Karsten and Lena and Albert, thank you very, very much. It was greatly appreciated and some good advice for us.